Good morning, everybody. My talk is on conventional laser treatment versus PDT and CSER. So conventional laser treatment to start with, it's very simple, argumentative, as there's a focal leak and we treat the focal leak and the subretinal fluid is gone. Effective in almost 90% of cases, and it requires less learning curve. However, prerequisites require FFA, OCT plus or minus, because we can monitor the fluid whether it's resolving, and obviously the laser console. So acute CSR usually refers to the self-limiting CSER that resolves spontaneously over a few months, that is 3 to 6 months, without any treatment and minimal residual changes on imaging. Laser photocoagulation may be required if serous detachment persists beyond 4 months. The disease recurs in eyes with visual defects from previous episodes. The permanent visual deficit is present from previous episodes in the fellow eye, or the chronic signs develop like cystic changes in the neurosensory retina or widespread RP abnormality, or the patient, if patient occupational needs require prompt restoration of the vision or stereopsis. So mechanism by which focal laser works is it creates the grade 1 burn over the point focal leak site, which induces low grade RP inflammation. It closes the point leak site and hence the resolution of subretinal fluid. So FFA guided focal laser is applied to the exact point of the leak, which is detected in early frames. The power and the duration is titrated via the continuous wave test burn in the nasal mid-periphery. So this is the picture showing smokestack appearance. The lower picture shows pre-focal laser OCT picture, and the other OCT picture shows after focal leak, the SRF is resolved. We can also see the choroidal thickness in the OCT picture. This is a ink blot pattern. So pre and post focal leak pictures are there on OCT. Fluid is resolved nicely. But treating the focal site doesn't address the underlying pathology in choroid, and in few cases we cannot treat with focal laser, such as multifocal leaks, or in lower picture subfoveal leaks, or the diffuse leakage in this case. Both the eyes is showing diffuse leakage pattern on FFA, and OCT is showing subretinal fluid with cystic changes. The other eye is also showing cystic changes on OCT. Over to chronic CSER. It is defined by symptoms lasting more than 6 months, and also by fundus biomicroscopy we can see persistent subretinal exudation, extensive RP atrophy, CMD, which is called cystoid macular degeneration, and rarely CNVM. ICG angiography can be used to see diffuse or multifocal areas of choroidal hyperpermeability. Currently, no standard treatment for chronic CSER is there. Our experience with photodynamic therapy, photodynamic therapy is FDA approved only for CNVM and pathological CNVM secondary to pathological myopia. This is a small video showing, anyways, I skipped to it. Whether PDT can be off-labelly used for idiopathic CNVM, inflammatory CNVM, polypoidal choroidal vasculopathy, vascular tumors like circumscribed choroidal hemangioma, and chronic CSER. However, treatment success is limited by complications such as choroidal ischemia, RP atrophy, RP rips, and subretinal hemorrhage. The picture is showing RP rip here on the FFA. Now PDT, there are two type of PDT we use, which is standard fluence and reduced fluence. Reduced fluence can be light dose, where light dose is given as 25 joules per centimeter square, and light fluence is 300 milliwatts per centimeter square. So this is the picture showing standard fluence in CSER case. The PDT is done in this area. You can see the choroidal ischemia on ICG, and corresponding SRF is resolved but with residual foveal thinning, whereas reduced fluence PDT is showing minimal choroidal ischemia. SRF is resolving with normal foveal contour. Over to safety enhanced PDT, it can be half dose or half fluence. In half dose, we give lower dose, which is 3 milligram per meter square, whereas half fluence, 25 joules per centimeter square or 300 milliwatt per centimeter square of energy is given. Recently, half-time PDT is also being described, where full fluence is given for only 40 to 42 seconds. PDT acts via short-term capillary hypoperfusion. It also causes cytotoxicity to vascular endothelium, platelet aggression, causing thrombus, and through long-term vascular remodeling, which decreases choroidal hyperpermeability. Now, PDT is also being described in acute CSER cases where they have shown complete resolution of SRF with improvement of vision. But in chronic CSER, we have various treatment strategies, which can be standard fluence, half dose or half time, or treatment spot wise, which can be FFA guided or ICG guided. Histology following PDT, it shows that despite choriocapillary occlusion, the photoreceptor inner and outer segment did not show any signs of degeneration. Dr. Lai also has described MFERG in CSR cases post PDT. We can correlate the OCT picture with improvement in multifocal ERG pictures and waveforms. Few authors have described standard fluence in chronic CSER cases with complete resolution of SRF, but there are complications associated with it, which are RP atrophy and juxtafoveal CNVM. Ribaldi et al. And Shin et al. Have compared standard fluence with half fluence PDT, showing that SRF is resolved by 1 year in all the cases with better visual acuity in half fluence group. But also they have not noted any sort of complications such as juxtafoveal CNP or RP atrophy in half fluence test. Our result or our experience with low fluence PDT also shows 85% of patients showing resolution of subretinal fluid, with 68% of patients showing more than 2 lines of improvement. Our study is a prospective non-randomized interventional case series study which consisted of 20 eyes treated with low fluence PDT. Inclusion criteria include severe cases of chronic CSER with exudative RD, subfoveal fibrin, PED, diffuse retinal pigment epitheliopathy. These are the few pictures of the patients. This picture is showing FFA with diffuse leak in juxtapapillary lesion over the superior arcade and inferior arcade. Corresponding OCT picture which shows minimal fluid. Following PDT, the fluid resolves and visual acuity improves. This is another picture showing subfoveal leak. Following PDT, again the SRF is resolved. This is a chronic CSER cases which showing RP degeneration and diffuse ooze on FFA. Also RP tract is seen. This is the autofluorescence image and OCT picture pre-photodynamic therapy showing subretinal fluid with PED, and post-PDT fluid resolves nicely but PED remains. So low fluence PDT was done with 6 milligram per meter square infusion of vertiporphyrin over 10 minutes, followed by a delivery of dial laser at 689 nanometer. 15 minutes after the start of infusion with a fluence of 25 joules per centimeter square, a light dose rate of 300 milliwatt per centimeter square, and a photosensitization time of 83 seconds. Spot size were determined by measuring the area of active angiographic leakage in the middle phase of FFA. Over to the results. Mean duration of symptoms in these cases was 21.5 months. With standard deviation of 17.39. 100% baseline OCT picture shows SRF with 85% of patients showing PED, and cystoid spaces were present in 40% of cases. FFA pictures shows diffuse ooze in 55% of cases, diffuse ooze with leaking PED in 5%, subfoveal ink blot pattern was noted in 15% of cases, subfoveal leaking PED was noted in 25% of cases. Following PDT, SRF was persisting in 15% of cases, whereas it resolved in 85% of cases. Central macular thickness improved from 362.6 micron to 209.5 micron. and visual outcome improved 0.65 logMAR units to 0.39 logMAR units. Post-treatment OCT, cystoid spaces were persisting in 20% of cases, RP degeneration was present in 30% of cases, and foveal thinning was present in 40% of cases, which accounts to 30% of the patients which did not improve after PDT. Mean duration of resolution was 5.41 weeks, which is corresponding to most of the Western literature. Half fluence, there is only one study which compares half dose versus half fluence done by Massimo Nicolo et al. It shows SRF resolution in 100% cases in half dose and 83.9% of cases in half fluence. But both half dose and half fluence photodynamic therapy are safe and effective treatment alternative to chronic central serous retinopathy. However, no complications were noted, such as RP atrophy in both the groups. In summary, tailoring the therapy to obtain the maximal treatment effect with minimal toxicity is essential in treating patients with CSER, since they usually have relatively good baseline visual acuity. PDT is an excellent treatment option in chronic CSER. Half fluence or half dose PDT can achieve comparable, if not possibly superior outcomes to standard fluence PDT, while decreasing the risk of adverse side effects such as foveal atrophy, CNVM, and choroidal ischemia. Thank you.